The PIONEER is it's a big data project that is done together with the EAU, the European Association of Urology, and many other partners, the industry, patients advocacy groups, clinicians, engineers. So it's a very big project. So the second studyathon was about a research question. The research question was regarding metastatic hormone-sensitive prostate cancer, and to know and to develop a prediction model that probably help us to select the best treatment according to the outcomes. The outcomes, of course, can be clinical and oncological outcomes. This was the objective or the main topic of the studyathon. Why we select or why we did this research question? Because it's linked to what I have said before. Nowadays, we have many tools in metastatic hormone-sensitive prostate cancer. We have radiotherapy, new hormone agents, we have chemo, we have combination, we have intensification, and we don't have any tool that select us which is the best treatment for each patient. Nowadays, we do it in a subjective way, let's say. We do it based on clinical parameters. For example, if the patient is symptomatic or is asymptomatic, on the number of metastases, and things that probably might change according to the country or the hospital or the clinician input. And we know that the first line that we pick for these patients is very important, because we know from real-world data that most of these patients will receive only one line of treatment because they progress or they die. And if they progress, many of them won't have the baseline characteristics to receive a second line. And the sequencing is very bad. Although we might hear, or although we might read that some sequencing is possible, of course, sequencing is possible, but almost less than 50% response to sequencing. So the first option is very, very important. So the main objective of the studyathon was to find a tool that help us to select the best treatment option in these patients using real-world data and using big data. And the main findings of this studyathon were that real-world data is completely different from what we find in the randomized control trials. Because the word randomized control trials say is controlled. All the variables of the patients that are included in the studies are controlled by a protocol. So this makes that the population from a randomized control trial is completely different from what we get in real world. I can make you many examples of what we have found in the studyathon. We have found that the age is higher. The mean age of the patients with metastatic hormone-sensitive prostate cancer is higher from those from the randomized control trials. The number or the kind of comorbidities is completely different. We found that the treatment patterns are completely different. For example, although we say nowadays that ADT, it's no longer the standard of care, it has to be ADT plus something, we found that 1/3 of patients in real world is treated with ADT only. We don't know why is this. Probably is because of resources, probably is because of not having available all the treatments, but we need to know the results. We need to know what is happening in real world in order to make changes, make policy changes that benefits our patients. At the end, we try to make this prediction model, and the prediction model has an accuracy of 75% of predicting death in the first year, which is not bad. There's still data to be run. But we know from this model that those patients that have, of course, more than 90 years, has variants different from adenocarcinoma, has liver metastasis, has visceral metastasis, has a T4 or very, very high PSA values, will have 60% of probabilities to die in the first year. This is what our prediction model says. But as I said, this is preliminary data. We're still waiting to analyze more claims that we're receiving, and we will have more mature data to present probably in another meeting.